Before we do our live CIMT demo, let's do a quick review just to get everyone oriented and on the same page with terminology. This video assumes you're already familiar with what a CIMT is and how it works. If not, I want to encourage you to watch this video first because we're not going to spend a lot of time here explaining what a CIMT is. Your arteries are built in layers. The outermost layer is the externa, also known as the adventia layer. The middle layer is the media layer, and the innermost layer, which is also the thinnest and most fragile, is the intima layer. Plaque forms between the media and the intima layers. As it gets worse and worse, you end up with something like this between those intima and media layers of the artery wall. Using ultrasound, you'll be able to see those intima and media layers of the artery wall, the plaque, and what kind of plaque it is, in real time. How cool is that? The carotid arteries come up from the heart and run along either side of the neck. Just before the jawbone, they split. One branch goes external to the skull, that's the external carotid artery, or ECA, and the other branch goes inside the skull, that's the internal carotid artery, or ICA, which you really can't see on this image because it's up underneath the jaw. The split is called the bifurcation. In this area, the arteries tend to bulge out a little, so we call that the bulb. Now this is really important because we'll be using the bulb as our primary reference point for all of our measurements. The main trunk coming up from the heart is the common carotid artery, or CCA, and this hollow area inside the artery is called the lumen. Now don't worry about memorizing all of this stuff. We're going to learn it through sheer repetition as we walk through the live demo. The ultrasonic sensor will be placed on the right side of the neck to look at the right artery, and the left side of the neck to look at the left. This is the lateral, or side view position. We'll also move the sensor more to the anterior, or frontal view of the both sides, and to the back, or posterior view of the arteries, so we can see the arteries from multiple angles. First, we'll locate the common carotid artery down here, well before it splits into the internal and external arteries. We'll look for the circular outline of the artery in this transverse view. It gives the technician an easy way to quickly locate the artery and get the ultrasound equipment focused and calibrated on the artery. The technician will then rotate the handheld sensor to look at the artery lengthwise, that's the sagittal view, and then move the sensor up the artery to where it splits or bifurcates at the bulb into the internal and external carotid arteries. The sensor will be on the neck. The ultrasonic waves will pass through the near wall of the artery and focus on the far wall. Keep this graphic in mind because it's the exact same orientation we'll see when looking at the ultrasonic imagery. We focus on the far wall because it gives us more reliable results. The CIMT measurements are done right before the bulb, over a 10 mm length of artery for the lateral view and again for the anterior and posterior views, when possible. Some folks' anatomy makes some of the other views too hard to reach. Hopefully, my anatomy will cooperate. And of course, we repeat all of that for the left carotid artery. Those results are then sent to the radiologist, and then you get a report summarizing all of this with some numbers indicating your peak and average into media thickness values. Some companies even provide still images of your arteries. We'll take a close look at those reports in a separate video. Okay, now that we have a solid conceptual understanding, we're ready to see the real thing. Now, I'm not a doctor, and I'm not fully trained in ultrasound or anything else medical. What you're about to see here is simply my understanding of what we're looking at, so please don't take it as medical advice. If I misunderstood something or say something that's incorrect, or you don't quite understand something I say, please leave a comment below so we can all learn together. I do want to give a big shout out to Atlanta Ultrasound. They allowed me to record this during a training session. The technician doing the test is also not a doctor, so again, nothing here should be interpreted as medical advice. We'll look at the official reports from the radiologist in the next video where we'll see the actual medical results. I have no affiliation with Atlanta Ultrasound. I'm just a satisfied customer that really likes the way they do business, and I'm grateful for their help with this project. And one final note. The video we're about to see is a full carotid artery scan, which includes both a CIMT and a Doppler flow analysis of the carotid artery system, which explains why this video is so much longer than a typical 10 to 15 minute CIMT. Put the sensor on the neck to look for the right common carotid artery using a transverse view down the neck way below the bulb. And there's the right common carotid artery. This is the end of the carotid closest to the heart, which they call the proximal view. The technician's looking around and fine-tuning things on the machine. Grab a snapshot of the proximal view. Snapshots get captured in this pane over here. We move the sensor up the neck to the midsection of the common carotid artery. This is roughly where the artery passes by the thyroid. Grab a snapshot of that. Now we'll switch to sagittal view by rotating the sensor. And look at that. We can actually see the artery's intima and media layers coming in and out of focus as the sensor moves around. Let's freeze the video for a second. Again, the sensor is up above the screen, beaming sound energy this way. This is the artery, this is the wall closest to the sensor, and this is the intima and media layers of the far wall. Just like in the diagram we saw earlier. The diameter of the common carotid artery is similar to a pencil, and the thickness of the intima and media layers combined is about the thickness of a credit card. Let's resume the video. The intima and media layers come in and out of focus because everything's moving around each time the heart beats or I swallow, etc. Grab a snapshot of that. This looks very clean. No sign of plaque. Nice smooth walls. But we really don't expect to see plaque down here because we're in the midsection of the carotid artery and the blood's free flowing without obstructions here. Enable the flow indicator. The different colors indicate direction of flow. Blue is flow away from the sensor, and red is flow towards it, which depends on how the sensor is angled relative to the blood flow. It helps us locate plaques that might not be visible. Since the color fills the entire lumen, the hollow center part of the artery, we know there isn't any obstructive plaque. If there was plaque, the flow would show some kind of disturbance and you would see more turbulence in the flow colors. They wouldn't be uniform like we see here. They can also turn on audio so you can hear the flow as the heart beats. These waveforms will be important for us later. The technician is moving the sensor around and trying different angles, looking for any signs of plaque as we head up to the bulb where the artery splits or bifurcates. This is all looking pretty uninteresting. Lots of smooth intima media walls with no indication of inflammation or arterial damage. So far so good, but again, we don't expect early stages of plaque to accumulate here because the blood flow is unimpeded. We're now approaching the distal portion of the common carotid artery, which is the end farthest from the heart before it splits at the bulb. Now you have to use your imagination a bit, but this is the bulb. We'll come back and do the CIMT measurements here after we look around. This little white thing here is calcified or hard plaque right at the beginning of the bulb. We know it's calcified because the ultrasonic waves have trouble passing through it and we get a shadow or blacked out area below it. This is a very typical area to find plaque because there's more turbulence where the blood flow splits. That turbulence pounds on the artery wall and therefore is more likely to damage the artery, especially when you couple that with things like high blood pressure, which also stresses the artery walls. These little plaques aren't casting a shadow, so we know these are more heterogeneous or mixed plaques. Or, I suppose it could be where the intima is starting to scab over and form a fibrous cap over the damage. Regardless, we definitely see the intima and media layers getting thicker, which tells us we definitely have plaque here. Not good news. Let's move farther up into the bulb. The bulb's hard to see because we're looking at the bulb from this side. Picture one split heading to the left and one heading back into the screen. We'll see better views of the bulb later in the video. We see some more heterogeneous or mixed plaques up in the bulb. So this plaque is also in the process of becoming more stable and calcifying after damage that was done back when I was eating a crappy diet and had high blood pressure. It'll be interesting to see if this looks any different in next year's CIMT. And we'll grab a snapshot of that image showing the plaques. If you want to learn more about what causes the arterial damage and the plaque that forms in response to it, check out the book The Clot Thickens by Malcolm Kendrick. I think he really nails it. The color flow view isn't filling the entire lumen, which tells us there's probably soft plaque that we can't see. We also see there's not a uniform flow. There's mixed colors we expect from the turbulence in the bulb because the blood flow is being split and diverted. And grab a snapshot of the flow. Let's flip the sensor back to the transverse view so we can see all around the bulb instead of just one thin slice that we see in the lateral view. As we move through the bulb, we can now see the internal and external carotid arteries. This is probably the internal carotid artery because it's usually larger than the external artery. I assume that's because the brain requires more blood flow than the face. Now we'll go back and grab a snapshot of the start of the bulb. And there's that little calcified plaque we saw earlier from the side view. We'll measure that. Looks like it's 1.8 millimeters. Then we measure the width of the bulb, and we see it's 9.7 millimeters. So we have around a 20% stenosis or blockage of this artery. Now these are just exploratory measurements to show you how a measurement could be taken. This is not the CIMT measurement. We'll do the CIMT measurements after we've looked around some more. But I should mention that normally we would measure vertically. We would also be careful to account for the wider opening because we're entering the bulb here. We did this example at an angle just to make it easier to compare these two measurements side by side. Moving back up into the bulb, we see a better view of the internal and external carotid arteries. Let's grab a snapshot of that. Now we'll rotate the handheld sensor back to the sagittal view so we can see the long view of the artery. Move back up into the bulb. There's that little calcified plaque again. Keep moving up towards the jaw to find the ICA. I had to rotate my head to the right to move the jaw out of the way so we could get a better view. It takes a lot of practice and patience to be able to reach the ICA and get a good image. We eventually do find and move up into the ICA, where we do see a little more plaque. Now just to be sure, we're going to turn on the audio because the internal and external carotid arteries have different velocity waveforms. The external flow to the face doesn't have far to go, and it quickly transitions into small blood vessels in the face, so it has a higher resistance and higher velocity of the blood. We see this is definitely the ICA because it has a nice gradual smooth transition between the peak systolic velocity and the end diastolic velocity. This is a good example of the difference between the two. The ICA has a nice gentle fall off. The ECA has a much more abrupt fall off due to the increased back pressure. Why? Because the ECA has a much shorter trip out to the face and transitions to smaller vessels quicker to service the face, so it's quicker to resist the blood flow. The ICA has to transport lots of blood to a larger volume inside the skull over a longer distance. The resistance to flow is calculated and shown here as the resistance index. It measures how much the blood flow is being resisted. Low flow being below around 0.7-ish, which this is. Remember that value to compare with the external waveform coming up next. We expect the ECA to be quite a bit higher. Now that we know for sure this is the ICA, we'll grab a snapshot. We'll also turn on the color flow to see if there's any soft plaque hidden from our view. We see a nice full flow across the entire ICA artery, so that's good news. We have free blood flow directly into the brain. Cool. Now this is especially important because we tend to lose visualization this far up the neck, and it's harder to focus a sensor on tiny details because the sensor bumps into the jaw. Again, the colors tell you how the sensor's angled. Orange means the blood's flowing towards the sensor. We'll grab a snapshot of that. And if we change the angle of the sensor, we see blue, so blood is now flowing away from the sensor. If we don't see any flow, well, it's time to worry. So this is all looking great. Now we're just looking around and trying things from different angles and using audio waveforms to assist our exploration. As you can see, we have lots of ways to find plaques and obstructions when this technology is in the hands of an experienced, well-trained ultrasound operator, which we call a sonographer. We're just looking for any anomalies we can find. Now we go back down to the bulb and head over to the external carotid artery. Enable the audio, and yep, we see a much more abrupt and therefore higher pressure change waveform and higher resistive index. Anything above 0.85 is considered higher, all of which helps confirm we are looking at the external carotid artery. This little bump in the waveform is called the Dicrotic Notch. That's where the aortic valve closes, so we see a bump in the blood flow. If we don't see a nice abrupt bump, then it means the aortic valve might have issues. Looks like mine is solid. That's good to know. Now we'll head back to the bulb and finally take our CIMT measurements. Everything we've done up to now was just exploratory and not part of the CIMT. As you're about to see, the CIMT is pretty quick. This is a textbook view of the bulb where we see the calcified plaque and the areas with the widening distance between the intima and media layers of the artery. This is the area we want to measure for the CIMT. Let's freeze that image. Now we could throw an IMT box up on the screen and take a measurement. But how do you ensure that the next one you do in a year or so covers the exact same area so you can accurately compare the two? I can't emphasize this enough. It's incredibly important that the ultrasound operator measures the CIMT the exact same way each time. So make sure the company you use has a strict, well-defined protocol so when you come back for a follow-up CIMT, you're comparing apples to apples. This is how Atlanta Ultrasound does it. First, they mark the start of the bulb, which is right here, and come out 1 millimeter and drop another marker. Next, we bring up the common carotid artery IMT measurement box. This is the lateral view, and align it with the edge of the cursor that we placed 1 millimeter away from the bulb. Again, it doesn't matter if you choose the center of the marker or the end, as long as it's done the exact same way each time you get a CIMT, so you know you're measuring the same thing. Now we want to center the box vertically so the artery wall is in the middle of the box. Hit measure, and if you look closely, you can see where the machine outlined where it thinks the intima and media layers are. If it doesn't look right, well, just move the box a little and try again. You want to make sure the machine didn't pick up any weird artifacts that throw off the measurements. This looks good, so we save these measurements. A typical healthy intermediate thickness is around 0.6 to 0.8-ish millimeters. My average is a good 40% above the middle of that range. Shoot, even my minimum thickness doesn't get that low. Well, that's not the best news. That was the lateral or side view. Now we're going to move the sensor more towards the front of the neck so we can get a different view of the artery. We're moving the sensor around the neck towards the face. This is the anterior view. Anterior means in front of. We're looking from in front of the artery, well, as much as we can before other anatomy gets in the way. This is a really good view. Here's the bulb, and we can see the artery wall isn't nice and smooth, so let's grab a CIMT measurement to see how bad it is. Same procedure. Drop a cursor at the start of the bulb, another cursor 1 millimeter upstream back towards the heart. Then grab our IMT box, anterior view this time, and center the artery wall in the box. Hit measure. Looks like the machine did a good job of finding the layers, and there's our anterior CIMT. It looks a little worse than the lateral view. Save that. Finally, let's do the posterior CIMT. That is, we're going to move the sensor back around the neck as far back as we can and still get a good view of the artery. It takes a few seconds of moving around to get a good clear view. We aren't seeing much plaque at all from this angle. That's good news. Okay, we got a good clean image. Let's scroll back a tad. Look for the start of the bulb. Mark the start of the bulb. Drop the second cursor 1 millimeter away. We want the CCA IMT posterior measurement box and place it. Oops. See this fall off here? That doesn't follow the media layer correctly, does it? It should go this way. The machine doesn't always get it right, so let's clear that and start over. It's really hard to get a clear image from this posterior angle because there's so much tissue between us and the artery. We'll keep trying till we get a good clear image of both the intima and media layers of the artery wall. There we go. Drop the first marker. 1 millimeter away, we drop the second marker. Grab the common carotid IMT box, posterior view, and move things around a bit till we get a good measurement. Notice that this box didn't start right at the edge of the cursor, so this really wasn't a good measurement that we'll be able to replicate later. But it is very representative of the area, so we'll go with it. This posterior angle is much more representative of what a clean arterial wall should look like. We're now done with the right side. Most experienced technicians can get both the right and left carotid artery CIMTs done in less than 15 minutes total. It took us a lot longer because we stopped to explain everything and did a full carotid artery scan. Now before we do the left side, let's stop and think about how incredible this is. Using a completely non-invasive, inexpensive, safe and quick procedure, we can actually see inside our arteries, how much plaque we have, and what kind of plaque we have, and where the plaque is located. And while we're not looking directly at the heart, studies tell us that the carotid plaque is predictive of coronary plaque around 83% of the time, and is predictive of future coronary events 95% of the time. That is, if you have plaque in the carotid artery, you're likely to have plaque in the heart. And just to give you an idea of how bad it can get, a friend of mine had carotid artery surgery to remove plaque, and he gave me these images to share with you. Usually they just scrape it out in pieces, but his plaque was so bad the doctors were able to pull out a good portion of it intact. We see the common carotid, the bulb, and the internal and external arteries branching off. You can also see it was still hollow and passing some blood. Man, I wish I had a CIMT video of that to show you guys. Holy cow. Okay, let's quickly zip through the left carotid artery so we can see how things look over there. Step 1. Find the left carotid artery using the transverse view. And there it is. Quickly run up the artery to see if there are any major issues. Looks good, so we'll switch to the sagittal view. There's the intima media layers of the artery wall. We'll move the sensor around until we get a good clean view of the artery. You can see the artery walls coming in and out of focus as we optimize the view. A quick look at the flow. Excellent fill. Don't see any hidden obstructions. Again, red is flow towards the sensor, and when we change the angle of the sensor, blood is now flowing away from the sensor. Still see full flow, so we're looking good. Get a quick audio to see if we hear anything odd. Nope, sounds good. And we still see the Dicrotic Notch, which tells us the aortic valve is closing in a good solid way. Keep working our way up the artery. The image is coming and going because we're looking around the artery from different angles, not just going straight up. Again, to get a better view of the whole artery, not just one thin slice. And we get to the bulb. Not a great view, so let's try again. And the blank screen is when the sensor is removed to apply more gel. Find the artery. Much better image. We can clearly see the layers of the artery now. And look at that. A textbook view of the bifurcation. Here's the CCA, the bulb, the bifurcation, the ICA, and the ECA. This bifurcation is where we most often find plaque because it's taking the brunt of the impact from the blood flow. Let's zoom in a bit. There's the bulb, and we'll grab an image of that. Do a quick flow check. Got a nice flow. Let's rotate the sensor to get a transverse view to help us locate the internal carotid artery. There's the split into the internal and external carotid arteries, so I'm going to back up to the bulb and grab an image for reference. Now that we have our bearings, we'll rotate the sensor back to the sagittal view to locate the ICA. The ICA is usually the lower branch, so we'll try that one. Do a quick audio check. And we see this is the ECA because the waveform has that characteristic jagged abrupt form. Now, while it's unusual for the ECA to be at the bottom branch, everyone's anatomy is different, so it's good we checked. No problem. We just move to the upper branch, which we now know as the ICA, and we do a flow check for hidden plaque. Gorgeous flow. Good news for me. Now this is an artifact, not plaque, and we move the sensor around just to be sure. Yep, looks good. Do a flow test, and full flow tells us that wasn't a plaque. And if we do an audio test, yep, we see a lower pressure waveform, so we're definitely in the internal carotid artery now. Okay, let's go back to the bifurcation where the common carotid artery splits, and this time put our cursor on the external carotid artery, which is usually the smaller one, so that would be this one. We also know this is the ECA because of this. It's the superior thyroid artery branching off at the ECA right where we expect it to be. It carries blood down to the thyroid, upper larynx, stuff like that. This flow highlights the bifurcation where the common carotid artery splits into the internal and external arteries. Do another audio test, and sure enough, we see the jagged waveform which tells us it is in fact the external carotid artery. And we still see the aortic valve closing solidly. So we've now confirmed the external carotid artery is the bottom branch, which again is unusual because the external carotid artery is normally on top. Good thing we checked. Okay, now we'll move around until we get a good view of the common carotid artery right before the bulb so we can do our CIMT measurements. Here's the bulb, internal and external arteries. Great, freeze that. Drop a marker at the start of the bulb, and then another 1 millimeter away. We're doing the left carotid, far wall, common carotid IMT, lateral view. Place the IMT box, and we get our measurements. And it looks like the machine did a good job of identifying the layers of the artery walls. Now remember, the sensor is up here, and we're looking through the artery at the far wall. Could we do this on the near wall of the artery? Sure, but it turns out the far wall gives us much more reliable and accurate readings. So when comparing CIMTs, make sure they're both looking at the same wall. We're now looking at the artery from the anterior angle. The sensor is now closer to the front of the neck. There we go. The bulb is up here. Let's grab a CIMT from this anterior angle. Drop the markers. Select the anterior IMT, drop the box,
And there's our intima and media walls of the artery. Now rotate the sensor around back behind the neck to get the posterior view. You gotta fish around to find it. There's a great view of the bifurcation. The bulb starts here. Drop the first cursor at the start of the bulb. Second cursor 1 millimeter away. Go grab the posterior measurement, drop the measurement box, and there it is.
We definitely see some widening here and heterogeneous plaque that's well on its way to being calcified. That's a good thing. And that's it. We're done.
This all gets compiled and sent to radiology for interpretation and analysis, and in a few days you get a final report, which is usually just a page or two of numbers. Of course, the patient never sees all the stuff you just saw in this video. Some clinics won't even give you still images, much less recordings of the proceedings, and they usually won't even let you record your own. So again, huge thanks to Atlanta Ultrasound for allowing me to share this with you. Now, this was my second year of doing CIMTs and was in early 2024. Join me in the next video where we'll go over my first CIMT report, which was a year before this one, and learn how to interpret the numbers. That was with a company called CardioRisk, one of the bigger names in the business. We'll then use those results as a baseline to compare with this one and future CIMTs. You can click on that video here.